Hello, everyone. I'm Carol Fleck, and on behalf of the ADDitude team, I'm pleased to welcome you to today's ADHD Experts presentation titled ADHD in Preschool, Early Diagnosis and Intervention for Young Children. Leading today's presentation are Drs. Alexis Bancroft and Cynthia Martin. They are psychologists at the Autism Center at Child Mind Institute. Dr. Bancroft is a nationally certified school psychologist and a leader in the field of early childhood development. She specializes in evaluations for autism and coexisting neurodevelopmental disorders, including ADHD. She has worked in schools, hospitals, and in outpatient treatment centers. In her current role, Dr. Bancroft advises parents on how to navigate a child's neurodevelopmental diagnosis. Dr. Martin is the Senior Director of the Autism Center. She's an expert in autism and co-occurring conditions, including ADHD. She has worked with children who have communication and developmental delays, social skills deficits, and more. Preschool-age children are typically active and easily distractible, so identifying symptoms of ADHD can be a real challenge, both for clinicians and for parents. It's not uncommon for clinicians to have conflicting opinions about what's considered typical behavior in young children. But for parents who want answers, this can be a frustrating journey. Today's speakers will help us differentiate between the typical signs of age-appropriate development and the symptoms of ADHD in young children so that families can get the interventions and support they need. We'd like to begin today's webinar by asking this poll question to our live audience. What challenges have you faced when discussing a suspected ADHD diagnosis with your child's healthcare provider? Please select your answers and comment in the text box under the video player to tell us more. For answers to common webinar questions about slides, transcripts, and certificates of attendance, click on the FAQ tab of your webinar screen. If you support the work we're doing here at ADDitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for ADDitude magazine. If you subscribe today, you'll be able to receive our annual Success at School issue, which has important advice from experts on how to help your child thrive in school. Sign up for ADDitude magazine today for yourself or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Click the magazine tab on screen to learn more. And finally, as we approach back-to-school season, ADDitude is offering a free self-guided course for caregivers. The course provides effective and practical solutions to the academic and behavioral challenges associated with ADHD in the classroom. Our free course also helps parents understand why their children may be struggling in certain areas. This week's course tackles distractions and focus. Next week's topic offers solutions to organizing and managing time. You can join anytime and gain access to the full curriculum using the link on screen. So without further ado, I'm so pleased to welcome Dr. Bancroft and Dr. Martin. Thank you so much for joining us today and for leading this discussion.
Thank you for such a warm welcome and good afternoon, everyone. Thank you so much for joining us today. Myself and Dr. Bancroft are excited to be here with you, and we are coming to you from the Child Mind Institute. So the Child Mind Institute, we are a leading nonprofit that is dedicated to transforming the lives of children. We seek to destigmatize learning, mental health, and neurodevelopmental disorders. We have a three-pillar approach in our work where we provide advanced research, clinical care, as well as public education with dissemination of information. What we'll be talking to you about today, we'll start with talking about ADHD across development, how those symptoms come about, how they manifest in young children. We'll go over what common behavior is, though, during the preschool years, because we, of course, do not expect preschoolers to be the most attentive and cooperative individuals. We'll review what are the early signs of ADHD. So how do you differentiate typical development from a possible symptom of ADHD? And then how is a diagnosis of ADHD made? We'll go over what the current evidence-based treatment guidelines are for ADHD, and then review how you can support a child with ADHD at home as well as school. So let's start with, what is ADHD? Well, ADHD stands for Attention Deficit Hyperactivity Disorder. It is the same thing as what people previously referred to as ADD. Now it's all one diagnosis of ADHD, Attention Deficit Hyperactivity Disorder. It is a neurodevelopmental disorder that makes it difficult for children to control their behavior as well as focus their attention. And this is the most common neurodevelopmental disorder of childhood, affecting roughly 6 to 13% of school-age children. So now, how do symptoms of ADHD actually cause impairment? Why is ADHD a problem for kids? Well, symptoms of ADHD can be problematic for children because it can make it difficult for them to complete their classwork. It can make it challenging for them to follow daily routines, both at home and at school. It can negatively impact their peer relationships. It can make it difficult to make friends, to keep friends, to solve conflicts. ADHD can make it very challenging for a child to remember and follow rules. And then it can also negatively impact their organizational skills. So there are common symptoms and characteristics of ADHD. Children with ADHD may daydream a lot. You may see that it's difficult for them to follow instructions. They can frequently lose things or forget things. So parents who have bought many water bottles, and every time you buy a new water bottle, your child forgets it or leaves it, or the sweater was left on the bus again. It can be very difficult to keep those personal belongings. Kids with ADHD can make careless mistakes, completing all of their math assignment, completing that math homework, doing it really well, and then forgetting to put their name on it or forgetting to turn it in. They can have a hard time organizing their materials and their personal belongings. This can come up in their schoolwork, in their home, in their room, in their backpack, anything that involves organizing and maintaining your own materials. It can be hard to complete routines or do homework independently because it's hard to stay focused. It can be difficult to sit still. There might be a lot of squirming or fidgeting. Some children with ADHD will climb or run excessively. They might interrupt often, so waiting when you have something that you want to say, or the teacher asks a question and you need to raise your hand. You might be more likely to blurt out the answer than to think to raise your hand and wait before you give that answer. There can be excessive talkativeness, where a child starts talking about one thing and it leads to another and leads to another and leads to another. It can be really hard to wait and take turns, and there can be difficulty getting along with other people. Now, these are characteristics that do not occur for every child with ADHD, but you can see different combinations of these characteristics across children. We know that when we think about attention, variability is the norm, not the exception. So it can be very common for children with ADHD to focus their attention on highly rewarding activities, like video games or YouTube or something that they really enjoy, but then have a lot of difficulty focusing their attention on mundane daily activities. Just because a child with ADHD can do something well in one situation doesn't necessarily mean they can do it consistently. It can be very hard to naturally organize themselves to complete daily routines, like making their bed or getting through a routine in the morning to get dressed and get ready to go to school. they can often know how to do something. So intellectually can walk you through all of the steps of what's involved, but not be able to do it independently. If we think about how many people are probably watching the Olympics right now, lots of people can probably explain how some of the gymnasts do something on a balance beam or on a floor routine, but just because you can explain what you saw doesn't mean you can do it yourself. It can be very difficult to remember and follow rules. That can be a big challenge, where every day can truly feel like a new day. So even though the child knew the routine the day before and you do the same thing every single day, it can be very difficult to know, oh, I need to start doing that now. I need to get my shoes on before I go out the door. I did that yesterday. I also need to do it today. It can be very difficult to remember those things. This can understandably be perplexing and frustrating for even the most patient parents and teachers. So when we think about ADHD, it is a neurodevelopmental disorder that starts in early childhood and then continues into adulthood for most children. Young children are going to predominantly start with having difficulty around hyperactivity and impulsivity, where then some challenges related to attention and distractibility will emerge more in the school age years. And then that difficulty with attention and impulsivity as it persists into the adolescent years can make kids more at risk for having increases in unsafe behavior or substance use. Given that most individuals with ADHD in early childhood will continue to have ADHD symptoms into adulthood, we do see that there's difference in the persistence of those symptoms over time, where the inattentive symptoms tend to start high for most kids and continue into adulthood. Whereas we do see a decline for some kids in the hyperactive and impulsive symptoms as they reach early adolescence, where those symptom manifestations tend to be more prominent in the early childhood age range. There is a high co-occurrence of mental health and learning conditions when a child has ADHD. So about a third of children with ADHD have more than one disorder. So about a third will have more than one disorder, and then another third will have more than two disorders, where there will be two or more disorders co-occurring with that ADHD. And what those disorders tend to be are behavioral disorders, autism, learning disabilities, mood disorders, and Tourette's syndrome. So now I'll pass it to Dr. Bancroft to talk about typical development in ADHD in preschoolers.
Great. Thank you, Dr. Martin. Okay. So what are those common behaviors for preschoolers? So preschool years are an exciting time of cognitive, physical, social, and emotional growth that bridges the gap between toddlerhood and the school-aged years. Preschoolers are often eager to participate during group activities. They are curious, they're affectionate, they begin developing a sense of humor. They're easily encouraged, discouraged. They can demonstrate intense feelings and emotions. They're active. They love playing physical games, and they may show off or demand attention. Young preschoolers are notorious for their shorter attention span of about 2 to 3 minutes for each year of life. And preschoolers can also have difficulty following adult-led activities for long periods of time. So during this period, the brain region responsible for executive functioning skills are just coming online. So executive functioning, which includes inhibitory control, working memory, and regulation skills, are in the frontal part of the brain. And working memory refers to the ability to hold on to information in mind long enough to do something with it, such as follow a single or multi-step direction. Inhibitory control is a child's ability to inhibit an expected response. It comes into play when we instruct children to look both ways before crossing the street, play a game like Simon Says, or delay gratification during that iconic marshmallow task, or wait until that fresh baked cookie cools before eating it. So executive functioning skills are akin to an airport having a highly effective air traffic control system to manage the arrivals and departures of dozens of planes on multiple runways. It's predictive of future academic performance and success. So children aren't born with these skills, but every child is born with the potential to develop them. And tests measuring different forms of executive function skills indicate that they begin to develop shortly after birth, with the ages of 3 to 5 as a window of opportunity for dramatic growth in these skills. Okay. So here we're seeing some of the common milestones noted by the American Academy of Pediatrics and the CDC in their 2022 review of the developmental milestones, in which they changed the criterion from about 50% of children achieving this milestone to 70% achieve the milestone by the age that's listed. So it could be clearer to parents when their child might be falling behind. So these selected milestones focus on the development of different aspects of inhibition and a developing sense of danger. So we also see an emerging awareness of social expectations and an ability to interact with peers. So now that we've talked about expected behaviors and milestones, let's talk about those early signs and symptoms. What we know from research is that some of the earliest signs of ADHD can emerge in infancy. So temperamental factors like high emotional reactivity and challenges with sleep were often associated with later diagnoses of ADHD. Developmental delays in the areas of motor development and language development have also been indicated. So in very early development, the period of infancy and toddlerhood, there's a wide range of what's considered developmentally appropriate. Therefore, the clinical onset and diagnosis can occur as early as these preschool years or around age 3. While we'll go into some of the red flags during the preschool years, it's important to note that we worry most when a child's behavior causes significant impairment in their day-to-day functioning. So while we know that the majority of preschool students will exhibit transient ADHD-like symptoms, of those, a smaller percentage will develop more persistent ADHD. So some of the signs and symptoms commonly seen for preschoolers include having difficulty attending for 5 to 10 minutes on a non-screen task by age 5, excessive climbing on furniture and jumping when the behavior might not be expected or even appropriate, jumping from toy to toy in the playroom or having a hard time sticking with one toy for very long. And some children have difficulty playing with toys at all, preferring more physical forms of play. So a child who has a hard time waiting or is impatient, indicating those challenges with those inhibitory executive functioning skills that are coming online. And if your child interrupts you frequently when you're on the phone or talking with other adults, a child who moves so quickly that they might run into other peers or furniture because they're not paying attention to the environment around them, or a child who acts without thinking in ways that can be unsafe, such as reaching for a hot chicken nugget and popping it into their mouth even after you've told them that it's going to be hot and they need to wait, or a child who's so excited to be at the zoo that they unbuckle their seatbelt and they try to leap out of the car before you can even get to them. So a child who has trouble following instructions or following daily routines, think back to when Dr. Martin discussed variability as the norm rather than the exception. A child who makes noises while working on their homework or doing other tasks, or one who's talking excessively, a child who's considered like bouncing off the walls or has difficulty calming their bodies or maintaining a safe body when it's really necessary to, a child who's highly reactive, or a child who's having difficulty socially, either because they're moving too quickly, they're missing the social cues of others, or is really reactive to their peers and can act impulsively, like hitting another child if that other child snatches a toy away from them. So as we've been alluding to, early childhood is a critical period of development and a time when children's brains are growing rapidly and are thus most malleable and most able to change. So we know that 90% of the brain is developed by age 5, although it doesn't stop developing then, but this provides a critical period of intervention where we can build new neural pathways before these patterns of behavior become more entrenched. So here you see a graphic that I love, which shows the attenuation of the disorder, as Dr. Martin referenced earlier. So with no intervention, there will be some individuals who no longer meet criteria for ADHD as they age, but then we see the impact of small changes in the preschool year and its effect as individuals move throughout their development. And then we see the dramatic compounding and long-term effects of a more robust early intervention program. So at this point, we've talked about expected development, early signs and symptoms of ADHD, and the opportunity for change during the early developmental period. So you can probably guess that we're in favor of intervening early. So while the last slide showed the potential long-term benefits in terms of ADHD impacting functioning across the lifespan in general, research also shows specific benefits of intervening early, such as improvement persisting beyond active treatment period, better academic performance, improved friendships, self-esteem, family life, and then the ability to monitor for those co-occurring conditions that Dr. Martin was talking about. So what should we do if you're concerned? First, you can talk to your pediatrician and have a frank conversation with them about what you're seeing within the home setting. Take notes about your observations of your child. Be specific and come to the meeting prepared. You may need to advocate if you receive a response that's really well-meaning and reassuring, but ultimately doesn't address your concerns. You can ask your pediatrician to administer rating scales, the most common being the Vanderbilt assessment scale, to you and someone who knows your child in a separate setting, such as a school or a daycare. If your child screens positive or if you continue to have concerns, then you can ask for a more comprehensive evaluation. So a diagnosis of ADHD can be made by a qualified pediatrician, physician, or mental health professional. So when seeking evaluation for ADHD, the provider should include an in-depth developmental history and clinical interview with parents and caregivers. It should include direct observation of your child's behavior. At such a young age, parents may wish to consider direct testing with a child. You may want to check for other neurodevelopmental conditions. And the benefit of direct testing is it will compare a child's performance to their developmental level. So a stronger emphasis should be placed on this direct testing if you suspect delays in other areas of your child's development, such as motor or language skills. Rating scales to obtain norm-referenced data, which can quantitatively determine if a child showing more behaviors associated with ADHD than their same-age peers. It's also important to include information from other trusted adults, as I said before, who are familiar with your child in different settings, as ADHD symptoms must be present across settings in order to qualify for a diagnosis. Comprehensive evaluation should look at ADHD symptoms, but also screen for other developmental and behavioral conditions. And then they should also determine if any medical conditions need to be further evaluated or ruled out. For example, if there's a medical etiology for the symptoms, you would want to see if further medical workup is needed, and those should occur before making an ADHD diagnosis. So I will pass it back to Dr. Martin.
Great, thank you. So then that leads us to, if your child's diagnosed with ADHD, then what? What are the next steps? Well, the frontline intervention for treatment of ADHD in preschoolers includes behavioral interventions first. So behavioral interventions mean these are changes that we're going to make in the way that we are interacting with the child, changes we're going to make in their environment to try to support their attention and behavioral regulation skills. So we think of these behavioral interventions as falling into 4 key blocks. We want to build consistency. We want to increase positive reinforcement as well as selective attention, because that helps us help the child to really narrow in on what it is that they should be focusing in on and how to regulate their behavior accordingly. We want to enhance the parent-child relationship, and we want to train parents in how to manage their child's challenging behavior. Because if we think back to that first slide, typically in the preschool years, ADHD symptoms are going to be predominantly predominantly show up as impulsivity and hyperactivity, as well as that reduced attention. But the impulsivity and hyperactivity can be very challenging for a child in their day-to-day, and it's important that we teach parents how to effectively manage that for their child. So what do those interventions actually look like? Well, when we're thinking about at-home strategies, we break these down into praise and play. We want to get parents playing and praising their child's behavior in specific ways. We also want to increase what we call antecedent supports. These are supports that set a child up for success. When we're really verbally talking at a child and telling them what we want them to do or what they need to do, it can be overwhelming and difficult for them to process. So we want to make some of that verbal information more visual. We can do that by increasing these antecedent supports and adding in visual schedules. We also want to break down tasks. So sometimes a task that seems to be pretty easy, like get dressed or put on your shoes, and it sounds like it's one task. There are actually many different micro tasks and skills needed to complete that. So we want to break that task down into the specific skills and steps necessary and teach each of those steps in a scaffolded way so that the child can do it successfully. We want to have clear explanation of rules, routines, and expectations. It's very important that we're not surprising kids of telling them about what a certain consequence might be or something that we were expecting and then upset that they didn't do when they didn't really understand that before it was actually expected. So we want to make sure that the rules, the routines, and the expectations are very, very clear. We also need to model behavior in practice. So it's very common for ADHD or ADHD traits to also run in families. So if you as a parent yourself have difficulty with organization or attention, you want to think about how you can utilize supports for yourself to really model behavior in practice in a way that it's going to help support your child's attention and behavior. We really want to focus on the positive, and we want to catch a child being good. So we want to catch them doing the thing that we would like to see them doing more of, and make sure that we are pointing that out and describing it. We also want to support kids in building friendships and approach it as being our child's social coach. We want to find extracurricular activities that are well matched to our child. So if our child has a high activity level and they have a hard time following rules and routines, well, we want to pick extracurricular activities that might match onto that well. So something that involves a lot of physical activity, but maybe is a little bit lower on the rules and on the rules of it. Or maybe we're adding in more private instruction when we have the ability to do that to help our child learn the skill to then go into a more of a group-based sport. So when we're talking about building structure and consistency, the visual schedules, I cannot stress that enough of how powerful those can be for kids. Putting down into steps of what it is that they need to do and having them have a way of checking off when each of those things are completed. So when thinking about routines, like morning routines or evening routines, needing to brush your teeth, pick out your clothes, get dressed, eat breakfast, brush your hair, having each of those on a visual so that the child can see what it is they need to do and then check off when they've done it. Visual timers can also be very powerful because it can be hard for kids to know when something might be coming to an end. And they might get upset when something is coming to an end. So knowing how much time is left can help them better regulate their own behavior. And then you want to give an advanced warning when a transition is going to occur. So you want to let a child know when there's going to be 1 more minute. And then 3, 2, 1, this is all done. Let me help you clean it up and move on to the next thing. And know that the child might be upset about that, and that's okay. So as long as we stick with those routines and do it routinely, they'll be able to adapt their behavior to those expectations. So simultaneously, we want to make sure that we are offering high rates of positive reinforcement. So you want to think about the ratio as being every one time that you offer your child a correction of their behavior, or you tell them to stop doing something or to not do something, you want to make sure that you have about 4 positive comments. So it is important that you are praising and praising often. Like, wow, thanks for coming to the table the first time I called you over. Or I love how you're sitting there working on your coloring sheet. I see you're making the elephant pink. That's so cool. I love how you're sitting there and focusing on coloring that. You simultaneously want to use some selective attention. So if there's a behavior that you would like to see less of your child, like interrupting, for instance, you want to use some planned ignoring where you do not respond to that behavior. Now, that means that you are ignoring the behavior. You're not ignoring your child, but you're not going to put a lot of attention on that behavior that you actually want your child to learn to inhibit a little bit more. And then when we talk about catching your child being good, that means that you want to pick up on those times when they are doing something that you really want to see more of. Like, I love how you got dressed on your own, or how you picked out your shirt without me even asking you to do it. Awesome work. For kids with ADHD, it's very important that we enhance the parent-child relationship, because you are going to be doing a lot of coaching and correcting of your child in many ways. And so your child is going to be more likely to accept some of those corrections or coaching if you have a really strong relationship. When doing that, you want to make sure that you're empathizing with your child's experience while maintaining the expectation of what you asked. So in the example where we've set a visual timer for a child to have a set amount of time for something they really like doing, and then we've given them a warning of when it's almost coming to an end, and then we've given them a 3, 2, 1. Oh, this is all done now. Like maybe the iPad is all done now. Now we have to go to dinner. And the child is really upset about that. We don't want to put the iPad back on. But we also don't want to tell the child they're not allowed to be upset. It's perfectly reasonable to be upset when you have to end something that you really enjoy. So we want to empathize with that by saying, I know this is hard for you. It's really difficult to turn off a show that you love watching. I hear you. It's okay to have big feelings. So this is empathizing with your child while also helping them move on and transition to the next activity. It can also be really helpful to establish regular special time where you're providing 5 to 10 minutes each day of undivided attention on your child, where whatever they do, you are not going to provide a correction in that 5 to 15 minutes. Now, you have to think about how much time should you start with. If you think in 15 minutes it's going to be hard to not provide a correction, then start with 5, because you want it to be 100% focused on your child and what they're doing and positive, without having any corrections or discipline to their behavior. You also want to think about the way you're giving instructions. So you want to avoid what's called let's instructions. We don't want to frame things as something that could be optional. So instead of saying something like, let's get ready for dinner, we want to break that down into very specific terms of what we want the child to do and make it clear that what we're asking them is not optional. So instead of saying, let's get ready for dinner, try, please wash your hands, or it's time to wash your hands now. You also don't want to frame a direction in the form of a question, because if you frame it in the form of a question, it's very reasonable for the child to say no. If you say, do you want to eat dinner now? And the child says no, well, you asked it in the form of a question. So if you're actually saying it's time for dinner now, you want to frame it that way. So as example, if you want your child to put their shoes on, instead of saying, can you put your shoes on? You want to frame it as, please put your shoes on now. You also want to be very specific. So instead of saying something like, be a good boy or be a good girl, you want to say very specifically what you expect. Like, listen to your babysitter on your way home from school today. And you don't want to overwhelm a child with too many steps at one time. You want to make sure that you give one step at a time. So instead of saying something like, it's time to go, finish your breakfast, put on your shoes and grab your backpack, say, please finish your breakfast now. And then pause and wait for the breakfast to be done before you give the next step. You want to make sure that you're providing natural and consistent consequences. This means that you're going to calmly follow through with a natural, consistent consequence for an inappropriate behavior. You want to make sure that something like hitting, that there's a clear limit, that the child cannot hit. So you have said, you cannot hit your brother. If you hit your brother, I will remove you. And then you want to make sure that your child knows what is okay and not okay with items like toys. So toys are to play with, they're not to throw. If you throw the toy, I will take it. And then we want to make sure that when we're doing something where there might be a safety concern, that we have paused and waited for the child to follow before we have followed through with something. So for instance, giving the direction of when we cross the street, you need to hold the adult's hand. That means you pause and wait for your child to hold your hand, and you do not start crossing the street until they've held your hand. It's important that you wait, and that might mean that that the street has to, a sign on the crossing guard has to go through another round before your child is ready to go. And so I apologize, Dr. Bancroft, I was supposed to pass it back over to you, so I'll send it back your way now.
That's okay, no problem. That was wonderful. So now that we've talked all about behavioral interventions, many of you are probably wondering about, what about medication? So in short, the American Academy of Pediatrics recommends behavioral interventions as the frontline intervention for ADHD in preschool age children, and also for those children who are suspected of even having ADHD. Behavioral interventions are always the first line of defense. But for children 5 and older, sometimes adding medication can be helpful. So some of the considerations that we have when we're thinking about medication is that medication can be indicated if behavioral interventions do not provide significant improvement. So if there continue to be moderate to severe disturbance in a child's functioning, or if the behaviors are so severe that they could be dangerous, think about the child impulsively unbuckling their seatbelt in a moving car and trying to open the door because they see the ice cream truck outside, or a child who might bolt across the street and not wait for the walk sign or hold an adult's hand. Those are the things that we're most worried about. Are those 3 things. And then also in different parts of the country, we also want to consider if there is no behavioral treatment options available, then we need to weigh the risks, the pros and cons of starting a medication before age 5 or before age 6 against the harm of delaying treatment in general. So what about school involvement? So in general, it's helpful to involve a child's school in their treatment program. So we know that children with attention and behavior challenges benefit from supports, and supported kids are kids who thrive. There's often concern, and we hear this all the time, around stigma. Parents do not want their children to be stigmatized, but without awareness, children with attention challenges may actually be more vulnerable to being misunderstood and to have their behavior misattributed. So, you might hear a teacher say like, oh, that child's so lazy. Well, no, the child's not actually lazy. The child's just having difficulty sustaining their attention. So some common school interventions will include things like a daily report card. So a daily report card commonly includes goals related to academic work, positive peer interactions, and adherence to rules. So behaviors to be targeted are usually agreed upon by teachers and parents, and it allows for daily feedback and daily communication on how a child is doing within the classroom. So often, you go to pick up your child from a pre-K program or even a daycare center that then goes up through pre-K, and you're like, how was Johnny today? And they're like, oh, he had a great day. And you're like, well, okay, but what does that mean? So often as parents, we want a little bit more detailed information, and this can help us not only work collaboratively with schools, but it can help us get really detailed information about what is actually going on within the classroom, and it promotes the communication between home and school, which we know is so important to bolster children's functioning in both settings. So in addition, accommodations such as movement breaks, visual schedules, clear directions, preferential seating, so maybe sitting close to a teacher, and access to peer models, so peers who are generally doing what the teacher's asking, so that a child who may be struggling to sustain their attention, if they sort of lose focus and miss the direction, they can look around them and say, oh, Sally's opening up her book. Maybe I should open up my book too. So all of these are important and can be incorporated. Movement breaks can be really creative. So, a child might be given the job of messenger, and, a teacher might give them a special letter that they have to deliver to the front office or to another teacher's classroom. And this is an opportunity to not necessarily call out that child, but to give them a special job so that they can get their body moving. And then we also want to highlight that children with ADHD have rights. So there are 2 laws governing special services and accommodations for children with disabilities. It's the Individuals with Disability Education Act, so IDEA, and Section 504 of the Rehabilitation Act of 1973. So children are entitled to a free and appropriate education. And under Section 504, children with ADHD qualify for a plan to offer accommodations. And then there are some children who will fall into the disability classification later on of other health impaired, but a disability classification under IDEA, and then they'll be eligible to receive program modifications and accommodations through an individualized education program. So the first step in this process is sharing your diagnostic evaluation with your school district, and then starting their process to determine your child's eligibility and how they'll be able to receive those supports and accommodations that will be most helpful for them. So when in doubt, we cannot have this conversation without highlighting that, you are indeed the expert of your child. You need to follow your parenting instinct. Listen to that nagging voice that you might have that's wondering, this seems like it's too much. This seems like it's really difficult. This seems like it's harder than it needs to be. Listen to that voice and start advocating for your child. Start looking for answers. Use professionals and resources as your guide on the latest empirically supported clinical guidelines for ADHD. Look to those experts to see, okay, I'm concerned, I have concerns, but what am I going to do about this? So that you can get really good advice. And then if professional advice doesn't feel right, then seek a second opinion. Always do what feels right to you and follow that parenting gut. So with that, we want to say thank you. And here's a link to the Child Mind Institute Complete Guide to ADHD. And here are some of our references. So we're excited to answer some questions from you.
Wonderful. Thank you, Dr. Bancroft and Dr. Martin. We appreciate that. Before we start the Q&A, I'd like to share the final results from today's poll question. We asked, what challenges have you faced when discussing a suspected ADHD diagnosis with your child's healthcare provider? 32% said they haven't faced any challenges. 28% said their provider dismissed their concerns. 25% said they've received conflicting information from different providers. And 11% said something else. Now to your questions. Are there gender differences in ADHD presentations in preschoolers? Someone asks.
Well, I think the topic of gender is a big one right now. And there's a lot of research going in to understand what differences are in gender in the expression of symptoms of neurodevelopmental disorders. When we're looking at ADHD specifically, right now, there's no conclusive evidence that says we're going to see major differences in the preschool years of ADHD manifestation in biological sex females as compared to biological sex males. We do certainly see some differences as kids get older, often with biological sex females showing higher rates of internalizing symptoms and biological sex males showing higher rates of externalizing symptoms. So when we think about ADHD symptoms starting to fall within the more inattentive versus hyperactivity, impulsivity. Also, when we start thinking about some of the higher prevalence rates of having co-occurring conditions with the ADHD, like possibly some anxiety-based disorders, we do start to see some differences as kids get older, but there's not a lot of definitive information looking at that gender piece in the preschool years.
Okay. Someone asked, can you distinguish between ADHD and autism at the ages of between 2 and 3?
Oh, that's a great question. So, yeah, but so at 2 and 3, we can diagnose autism. At 2 and 3, to diagnose ADHD is more rare. So it's more rare to get a diagnosis of ADHD in a 2-year-old. As you're starting to get closer to 3, possibly, but it's still, you're going to really be more in those older preschool, early school age years. So between about 4 and 6, when if there's really prominent ADHD symptoms starting to come online and manifest, of when you're going to start to be able to more accurately make that clinical diagnosis. Now, what we know, though, with kids with autism is that a 2-year-old with autism, and we can reliably diagnose autism at 2, we do know that there are certain profiles of kids with autism that are going to have much higher rates of having co-occurring ADHD. So we'll often start to baseline what those ADHD symptoms are looking like in that age if we cannot also make that co-occurring ADHD diagnosis at that time.
Okay. Earlier, you had said kids could have transient ADHD symptoms, that it comes and goes. So we had a few questions around that, transient ADHD symptoms. Could you talk a little bit about that?
Yes. So it's pointing to non-persistent ADHD. So it's not transient ADHD per se, but that you are seeing symptoms of ADHD come and go in preschoolers, because we see preschoolers being more highly distractible and tending to be more active. So sometimes in the literature, it's been referred to as more transient ADHD-like symptoms, but not necessarily transient ADHD in general. Hopefully that's clear.
We had a few questions from teachers, not surprisingly. How can we teachers talk with parents of students who present with symptoms of ADHD, and how can we help parents determine when to test their child for ADHD?
I think that's a really great question. I think talking with parents about, and asking parents about how they experience their child at home, and starting with open-ended questions about the things that asking parents how they observe their child at home, how their child interacts when they take their child to the playground or other outings, and hearing what the parents say, and then picking up on those pieces of what the parents are saying, and relating that to what you also see within the classroom. So what that's doing is it's both building the across context that one would need in order to determine if a child would meet criteria for ADHD, because we would want to see them at home, at school, at a play group. We want to see those symptoms across context and happening. But I would start with open-ended questions. And then if a parent doesn't observe any of those symptoms, then you can share with them about some of the behaviors that you're seeing within the school setting. I think being as specific as possible can be really helpful. So not just saying, oh, I've noticed that Johnny, sometimes has a hard time paying attention. You could say, I've noticed that more often than not, when we ask the students to come to the center of the room for circle time, Johnny has a hard time putting away his toys and coming to circle time. Do you also notice challenges with transitions at home? Something like that.
Okay. Another question is, have you seen children with ADHD have issues with using the bathroom? For example, they're so engrossed in play or whatever it is that they're doing that they won't stop to go to the bathroom and they end up having accidents?
Yeah, I think we can just both give a nod and a smile. Yes, definitely.
Is there a way to...
Children... Oh, sorry.
I was just going to say, is there a way to, try and prevent that from happening in the future?
Yeah, I think we both probably have some ideas for this one. So I think it's really helpful to have a plan, a proactive plan in place for the child of when we're going to have scheduled bathroom time, and not wait to the point of an emergency, because it's hard for kids to have accidents too. And so, and those can have other types of consequences that kids can be bothered by. And, and sometimes kids actually aren't bothered by them, but it still then takes them away from the activity that they want to be in for a much longer period of time. So having scheduled time for the bathroom to try to prevent some of the waiting to the last minute, I think is the most helpful thing.
Okay, great. Someone asked, can certain diets, nutrition, and vitamin D help with ADHD symptoms in preschoolers and elementary school students?
Yeah, that's still a big emerging area where research has been looking at. There's certainly been studies that have been looking at different types of supplements or different types of what we call complementary approaches. And there's not a clear, yes, this is a thing, increasing vitamin D or using this supplement will have this benefit on a child with ADHD. So when you look at some of those within more of a rigorous context, so looking at randomized controlled trials, we don't have evidence from a methodology like that yet. Okay. But that's not to say good nutrition is just good. So certainly also for a child with ADHD, good nutrition is good. So those are things that aren't going to hurt anything and are certainly beneficial for kids in general.
Okay. Someone writes, my child suffers with emotional dysregulation and attention difficulties. She doesn't sleep well. I often get called to her preschool because she's not able to settle down for a nap. She spits and hits and bites. What should I do?
Yeah. Oh, that sounds so tough. First of all, it sounds like you are in touch with the school, and I think that that's the first step. Secondly, I would reach out to your pediatrician, talk to them about the concerns that the school is bringing up. Think about if you're having any concerns within the home setting as well, and maybe start initiating some discussions around what are some structures that we can put in place. You can also ask the school what structure and support they're putting in place to help mitigate some of the challenges that your child's experiencing. And what we know is ADHD is a disorder of both behavior and emotion regulation. So it's regulation in general. So it's not so surprising to hear that she's having challenges both emotionally and behaviorally with her regulation. And you may want to think about is starting the process of talking with professionals about maybe what can we do about this.
Okay. So we had a few questions around this. Can you tell me how to advocate for my child when I'm told it's just normal preschool behavior? And we had similar questions saying that a pediatrician wants to wait until a child is older to make a diagnosis. So how can these parents advocate for their children?
And we probably both have good stuff to say about this. I think one thing, I'll say one thing, then I'll pass it to you, Dr. Bancroft. I think one thing that's helpful is to ask for rating scales, because rating scales, especially norm referenced rating scales that actually compare your child's attention, behavior, impulsivity, hyperactivity, compare them to a normed group for their age. And so that can help understand, are there higher rates of behavior that are higher than other kids their age, and that it's not just normal preschool behavior, and have that filled out by multiple people.
Yes, I think definitely the rating scales, and also it's okay for you to be the expert in your child. You can say, I understand your perspective, and I've looked into this, and I know that symptoms of ADHD can emerge very early in childhood, and this is difficult, and this experience is challenging, and I would like to look into this further. You can request for them to do something about it. And you can say, if you don't feel comfortable making such and such referral or sending out rating scales, then can you please direct me to somebody in your practice who might feel more comfortable doing that?
Okay.
Sometimes you have to be really firm.
Yes. Yes. Someone asks, how do you help your child when the other parent is worried about labeling our child and refuses to talk about the possibility of our child having ADHD or allowing anything to work on behavior issues?
That's a really hard one. That's such a hard, and it's such a common experience too for families. And I think one thing is thinking about it from the other parent's perspective, that it's likely coming from a good place. It's coming also from a place of fear and worry. Both parents want the best for their child, and the way that they're navigating that is in kind of thinking about what's happening with their child is different. So I think it's really important to find a way to join around what the goal is, which is to make sure that your child is happy, healthy, supported, and see if there is agreement around a certain observation being problematic for the child, and try to make it really clear that, they can't sit with us for dinner, or we're not going to restaurants. We're changing things as a family because this behavior or how our child is navigating this environment is problematic, and it's problematic for our child. It's problematic for us as a family. And we want to help them to be able to go into these situations and be more successful. And so I think thinking about it, kind of putting the diagnosis aside and the treatment approaches aside, and focusing more on what is it that you want to see your child be able to do and be successful
Okay, well, unfortunately, that has to be the last question because we're out of time. But Dr. Bancroft and Dr. Martin, we thank you so much for joining us today and for sharing your expertise with our ADHD community. We appreciate it.
Thank you so much for having us.
And thank you to today's listeners. If you would like to access the event resources, visit ADDitudeMag.com and search podcast 516. The slides and recording are posted a few hours after each live webinar. If you're listening in replay mode, simply click on the episode description. Please know that our full library of ADDitude webinars is available as a podcast. It's called the ADHD Experts Podcast, and it's available on all streaming platforms. We hope to see you again next week for a free webinar on practical strategies to support your child's success at school. Make sure you don't miss future ADDitude webinars, articles, or research updates by signing up to receive our free email newsletters at ADDitudeMag.com/newsletters. Thanks, everyone. Have a great day.